Welcome to our clinical case presentation on Patrick. Patrick is a 78-year-old male who has worsening of his left-sided heart failure and COPD. He is very tired and coughs regularly and suffers from dyspnea. His legs are swollen from the knee down and he walks slowly. Patrick's current observations, body size measurements and fasting blood results can be seen on the slide. His previous relevant history includes smoking from the age of 20 until he quit in his early 60s and a myocardial infarction to a branch of his left coronary artery at the age of 68. Patrick's respiratory systems are attributed to his history of smoking, worsening of his left-sided heart failure and truncal obesity. Smoking affects the defense mechanisms of the lungs against airborne toxins, pathogens and irritants. Patrick had smoked for approximately 40 years of his life. This long-term assault causes various strains on the defense mechanisms of the lungs. Consequently, resulting outcomes include an increase in mucus production by goblet cells and structural columnar cells being converted to goblet cells, further increasing production. This results in an enhanced cough reflex, evident in Patrick's case, which further increases the production of mucus. The excess mucus production obstructs the small airways and subsequently the bronchi. The function of the cilia is impaired by the nicotine in cigarette smoke. Therefore, the buildup of mucus is unable to be cleared, leading to accumulation of mucus in the lungs. This creates a reservoir for bacteria in the lungs. Therefore, cigarette smoking is a common risk factor in the development of COPD and is most likely the leading cause of Patrick's development of COPD. Patrick's dyspnea is likely a result of his worsening left-sided heart failure. Heart failure is a syndrome encompassing several different types of cardiac dysfunctions that result in inadequate perfusion of tissues with oxygen and blood-borne nutrients. Left-sided heart failure impairs the ability of the left ventricle to fill with or eject blood, leading to congestion in the lungs and pulmonary edema. A common symptom of this congestion includes dyspnea. With a height of 180 centimetres and a weight of 95 kilograms, Patrick's BMI is 29.3, classing him as overweight. Patrick's waist circumference is measured at 104 centimetres, indicating that Patrick has truncal obesity. Respiratory functions are impaired in obese individuals, where truncal obesity makes the expansion of the thoracic cage more difficult, leading to symptoms of dyspnea, such as that suffered by Patrick. Dyspnea may also be related to Patrick's low hemoglobin. Patrick's range of 111 grams per litre is considerably lower than the reference range of greater than 130 grams per litre, indicating Patrick could have anemia. Patrick is seen to have an elevated heart rate of 155 beats per minute, indicating a state of tachycardia. The underlying cause being a result of his COPD caused by smoking and his evidently low hemoglobin. Patrick's extensive history of cigarette smoking has provoked direct consequences to his respiratory system, such as his development of COPD. Inhalation of nicotine stimulates the release of catecholamines known as adrenaline and noradrenaline, which are recognized to increase heart rate and peripheral vasoconstriction, therefore being a contributing factor to his high heart rate. However, the smoking has also likely had an indirect effect on his respiratory system, leading to other problematic health consequences and an increase in heart rate. As has been mentioned, Patrick's smoking is a likely factor in his development of COPD. Patrick likely has COPD characterized pathologically by emphysema, with the major cause being smoking. Resulting characteristics include increased volume of air in the alveoli, loss of normal elastic recoil of the bronchi, ineffective gas exchange, significant ventilation perfusion mismatching, and hypoxemia. In this instance, where respiratory function is impaired due to increased work of breathing or physiological dead space, as in emphysema, a state of hypercapnia could occur. One of the net effects usually including an increase in heart rate as characterized by Patrick. Patrick's hemoglobin count of 111 grams per litre is also noticed to be lower than the reference range of greater than 130 grams per litre. Low hemoglobin status may result in anemia. Patrick expresses that he is feeling very tired, one of the evident characteristics of anemia being weakness and fatigue. Chronic inflammation, such as the COPD diagnosed in Patrick due to smoking, is also linked as a common cause of anemia. In cases of anemia, initial compensation for cellular loss is movement of interstitial fluid into the blood, causing an increase in plasma volume. This movement maintains an adequate blood volume, but the viscosity of the blood increases. The thinner blood flows faster and more turbulently than normal blood, causing a hyperdynamic circulatory state. This hyperdynamic state creates cardiovascular changes such as increased stroke volume and heart rate. However, because Patrick's underlying anemic condition has not yet been corrected, it will likely lead to cardiac dilation and heart valve insufficiency. This leads to an increase in peripheral blood flow and venous return, which further contribute to an increase in heart rate and stroke volume in efforts to meet normal oxygen demand. Patrick's left-sided heart failure came as a result of the myocardial infarction to a branch of his left coronary artery at age 68. The acute myocardial infarction results due to prolonged ischemia causing irreversible damage to the myocytes. Patrick's COPD was caused due to smoking, spanning over a period of 40 years. The airflow limitation is caused by damage to the small airways as a result of the airway inflammation by parenchymal destruction, as a result of the loss of alveolar attachments and decrease in elastic recoil. In Patrick's case of left-sided heart failure, when the left ventricle fails, filling pressures on the left side increase and vascular volume redistributes into the lungs, causing an increase in pulmonary capillary hydrostatic pressure and a backtracking of excess fluid into the lungs, pulmonary hypertension, which then led to pulmonary edema. Pulmonary edema causes increased work of breathing and symptoms of dyspnea, therefore worsening Patrick's symptoms of COPD. Patrick's history of smoking is one of the factors that contributed to his development of the myocardial infarction, coronary heart disease, and impaired cardiac function. The coronary arteries supply blood flow to meet the demands of the myocardium. Smoking increases cardiac workload and oxygen demand. As this demand increases, healthy coronary arteries dilate to increase the flow of oxygenated blood to the myocardium. However, smoking can promote narrowing of the major coronary arteries and impaired blood flow enough to interfere with the cellular metabolism. This narrowing is caused by the formation of atherosclerotic plaques in the coronary circulation, potentially obstructing the vessels, causing ischemia. Patrick's myocardial infarction was therefore a result of insufficient blood flow and oxygen content required by the myocardial cells. Therefore, his smoking had a direct impact in the development of his left-sided heart failure. The function of the right side of the heart is to accept blood from the inferior and superior vena cava into the atrium through the tricuspid valve to the ventricle, where it is then pumped to the lungs via the right and left pulmonary arteries. As previously described, Patrick has pulmonary hypertension caused by the reduced contractility of the left ventricle and subsequent increase in left ventricular and atrial preload, resulting in blood pressure and volume increasing in the pulmonary veins. This elevated venous pressure and volume continues through to the pulmonary capillary beds, resulting in an increase in hydrostatic pressure. This in turn drives plasma into the lower pressure alveoli air sacs, resulting in pulmonary edema, as evidenced by Patrick's cough. Pressure increases are felt across the capillary bed to the pulmonary arteries, causing high pulmonary vascular resistance. As a result, the right ventricle increases its force of contraction and hypertrophies. Due to Patrick's COPD, he also has hypertrophied bronchial smooth muscle and hypersecretion of mucus, leading to airway obstruction during expiration. The resulting trapped gas, combined with the loss of alveolar elastic recoil, leads to decreased alveolar ventilation, increased partial pressure of carbon dioxide, and hypoxemia. Clinically, this is seen as Patrick's lethargy and dyspnea. Due to this reduced gas exchange, the coronary blood supply is unable to meet the higher oxygen demands of the hypertrophied right ventricle, leading to hypoxia-induced weakening of the force of contraction as the myocardial metabolism becomes anaerobic. As a result, the ventricular preload increases, and consequently so too does the atrial preload, as it struggles to empty into the partially full ventricle. The right atrium then too hypertrophies and suffers the same hypoxia-driven loss of force of contraction. Right-sided heart failure. Blood pressure and volume then builds up in the vena cava, leading to elevated central venous pressure down through the veins, venules, and capillaries. As the pressure in the capillaries increases, hydrostatic pressure exceeds interstitial pressure, and the fluid leaks out of the capillaries, causing the peripheral edema seen in Patrick's lower legs. The peripheral edema can continue to generalized abdominal edema, splenomegaly, hepatomegaly, and ascites. As Patrick's combined left-sided heart failure and COPD continues to limit both the oxygenation of the blood and supply of blood entering the kidneys through the renal artery, the structure and functionality of the renal arterioles, capillaries, and nephrons suffer from hypoxia. While Patrick's developing right-sided heart failure and increased central venous pressure and volume limit the flow of blood out of the kidney via the renal vein, resulting in structural and functional changes to the renal venules and nephrons due to edema. These factors combined progress to renal failure, as evidenced by Patrick's blood results. The function of the kidney is to retain or excrete sodium and water in response to arterial blood volume or pressure, which it is doing, but without the self-monitoring RAS system, leading to hypernatremia, a high blood sodium concentration of 150 millimoles per litre. Patrick's progressively failing kidneys are also not functioning to excrete potassium, resulting in hyperkalemia, or a high blood concentration of potassium at 5.2 millimoles per litre. Patrick also exhibits hypocalcemia with a low calcium blood concentration of 2.05 millimoles per litre. Hypocalcemia is usually corrected by an increase in calcium absorption by the kidneys and an increase in the production of calcitrol by the kidneys to improve intestinal absorption of calcium and calcium resorption from the bones. Patrick's failing kidneys, however, are unable to achieve this. Likewise, a reduction in the oxygenation of the red blood cells entering Patrick's kidney as a result of his COPD should have triggered a release of erythropoietin to increase red blood cell production by the bone marrow. Patrick's low hemoglobin result of 111 grams per litre again indicates kidney failure. These abnormal blood results will also indicate an altered neurological function. Patrick's hyponatremia and hypokalemia will disrupt the initiation and restoration of action potentials involved in the neural excitation of the brain, while his hypocalcemia will hinder the synaptic transmission between neurons and skeletal muscle contraction. A low hemoglobin will result in insufficient oxygenation of the neural tissue, eventually resulting in neuropathy and cerebral edema, as aerobic metabolism and ATP production is limited. Progressive renal failure will also increase the urea blood levels, leading to uremia. Collectively, this will result in confusion, impairment of Patrick's cognitive function, and stiffened movements, as evidenced by his lethargy and slow walking pace. Patrick also has a fasting blood glucose level of 8.5 millimoles, being higher than the expected 6.1, indicating that he is progressing towards developing type 2 diabetes, which is in keeping with his high BMI and atherosclerotic-induced myocardial infarction. Hypoglycemia will cause an altered state of confusion, dizziness, and lethargy, as consistently high levels of blood glucose cause neuropathy and further the previously discussed nephropathy. In addition to this, Patrick's blood creatinine levels would also be abnormally high, above the expected 0.9 to 1.3 milligrams per deciliter of blood for men aged 18 to 60. Creatinine is constantly released from muscle, travels through the bloodstream to the kidneys, and is excreted through the glomerular filtration process. Ideally, the rate of creatinine elimination matches the rate of its production. A high serum creatinine would confirm either Patrick's renal damage or failure, or a reduced blood flow to the kidneys as a result of his congestive heart failure or developing diabetes, which is impairing his renal filtration.